It is very important to know the molecular profiling status at the beginning, especially in stage 4 patients, because we want to know how to personalize the medicine depending on the molecular profiling. For example, if we know that patient has a BRAF mutation at the beginning of the treatment, those are the patients that has very poor prognosis. Those patients don't have the luxury of waiting for the third or fourth line therapy. So based on the TRIBE study, if I know the patient's BRAF mutant, I will start the patient off by giving FOLFIRINOX-based regimen based on the TRIBE study showing there's a small overall survival benefit. So that's why the importance of the BRAF status. On the other hand, the RAS status is something we really want to know at the beginning, because that will sort of dictate whether we use anti-angiogenic agent versus anti-EGFR agent. I think the biggest dilemma right now in first line is we know the backbone, typically we use FOLFOX here in US, is that what kind of biologics do you add to it? Now if you know that patient is RAS mutant, it's pretty easy. You would start with usually FOLFOX plus BEV. Once you progress on FOLFOX plus BEV second line, typically we change the backbone to FOLFIRI, and we continue anti-angiogenic beyond progression. Usually it could be the BEV. There's data with ramucirumab, and there's a data with aflibercept. So these are 2-3 anti-VEGF drugs that you could use in second line once they progress on it. However, if you know the patient has a RAS wild-type tumor and it's a left-sided tumor, based on the post-hoc analysis on large couple of phase 3 studies, we know that there seems to be an OS benefit favoring the of EGFR arm in the left-sided tumor. Okay. Therefore, if you have a left-sided tumor, RAS wild type, I think you will have a discussion with the patient to see whether the patient would like to have EGFR drug plus bevacizumab. Now, the downside of the EGFR drug is that we get rashes, and patients are on the first line for a long time, so they suffer with a rash and a pyrrhinicia issue. However, there seems like an OS benefit. Therefore, that will be the discussion that I would have with the patient at the beginning to see if the patient would like to have EGFR versus anti-VEGF drug in a first-line setting in left-sided RAS wild type.
Our understanding of how best to utilize biologic therapy in combination with cytotoxic chemotherapy for first-line treatment is really guided by some studies that, while older now, really inform still our best practices in this population. And that's the CA-LGB SWOG 80405 and the FIRE3 study. The CA-LGB SWOG 80405 is a study that was completed in the US, where patients were treated with a cytotoxic backbone of either FOLFOX or FOLFIRI. In the US population practice, that was predominantly FOLFOX based, and then randomized to either cetuximab or bevacizumab in the key analysis. These were RAF wild type patients, and the question was really about the overall survival of this population. In unplanned analysis, it was identified that tumor sidedness was a major factor of impacting the overall survival of these patients, where the EGFR-based therapies had best outcomes in patients that were wild type for RAS-RAF and had left-sided disease. Conversely, the bevacizumab arms performed best in the right-sided patients. And this data is consistent with the FIRE3 study, a European study that was, while smaller, provided complementary information. The backbone here was FOLFIRI, and again, cetuximab or bevacizumab. The primary endpoint in this study was response rate, but overall survival data likewise showed a similar benefit favoring an EGFR inhibitor for a left-sided RAS-RAF wild-type tumor, and bevacizumab for the right-sided tumors.
FIRE3 was a randomized phase 3 study in first-line setting in a patient with KRAS wild type. It was a study looking at FOLFIRI plus cetuximab versus FOLFIRI plus bevacizumab. And the primary endpoint was response rate. And overall, the trial was negative as there was no difference in response rate. Now, recently, they had a final analysis, final results of the FIRE3 study. And in that study, they looked at what we call a per protocol analysis. And those are the patients that actually got at least 3 cycles of chemotherapy or had more than one baseline CAT scan done. In those patients, there was a significant improvement in response rate. Response rate is close to 77%, 78% versus 65%, favoring the arm of cetuximab. And that translated into a median overall survival difference about 7 months. Even the PFS was very similar. So there was always a question about why is the arm of EGFR inhibitor with cetuximab being the PFS being the same, but there's a difference in overall survival. And one of the hypotheses is that because of this high response rate, there's a what we call early tumor response you see, and also there's a depth of response you see with EGFR inhibitor. And we think that that correlates with possibly overall survival benefit. So in patients who are RAS wild type in left-sided tumor, where you're looking for for shrinkage of the tumor, downstaging it, or possibly for an OS benefit, I think it's definitely reasonable to use EGFR inhibitor in first-line setting in combination with chemotherapy in all RAS wild-type patients.
As a result of these studies and our improved understanding of the biologic underpinning of these results, this has now changed practice and guidelines. While the guidelines differ between the US and Europe, I think it's fair to say that the consideration of an anti-EGFR therapy is strongly encouraged in a left-sided RAS-RAF wild-type patient as part of the first-line chemotherapy regimen. This information is being used in my clinical practice, where the default discussion with the patient is really about an EGFR-containing first-line treatment because of the suggestion of an overall survival benefit. Now, practically, this has to be weighed with the side effects and discussion of the potential impact of that treatment. But overall, this approach, I think, provides the best outcomes for our patients based on the available data.